Respected Chair, colleagues, warm good morning again. So at the outset, I really thank Dilip for giving me a precedence and allowing me to present earlier so that I can catch up with the time of my return flight. So moving on from one advancement to the other advancement, which has really made a paradigm shift in the world of treatment of bradyarrhythmias, that is leadless pacemaker. So this gets emphasized from this picture. This is the picture of the person who got the first pacemaker. This was his cumbersome life. He had to go along with this device all along with a nurse along with him who would connect the electrodes all on. This is the life of the first implanter patient who got the device, but he started off his life in 1967, lived up to many generations of device changed. In fact, he outlived a surgeon who got it implanted, but that's the real life scenario that happens. From there on, we moved on to this conventional system that we implant all of them, what we have been discussing till now, more from here into the conduct system. But the thing that is going to take the world by storm is this. This is the world's smallest pacemaker, the leadless pacemaker, which has actually made a paradigm shift in the way we manage bradyarrhythmias. So why do we need this? Traditional pacing systems are very well reliable, but if you look at them on the follow-up, 3 event data rates are, we have a failure rate of conventional pacing systems to the tune of 15% on the acute and 16% on the long term. And where do they fail? If you look at the Achilles heel of conventional pacing system, it happens at twofold. One is a pocket-related issue, which is about 8%, including infection, hematoma, erosion, at the tune of 8% at the end of 5 years, and lead-related issues, which can be a lead fracture, like here, insulation breach of the lead, venous thrombosis from the subclavian vein thrombosis from a long-dwelling, indwelling lead, or a tricuspid valve issue from a lead, which happens to the tune of 11% at 5 years. So these are the Achilles heel in conventional pacing systems. Moreover, in this world of where people want cosmetic results, nobody wants a chest wall scar, nobody wants a bump, visible bump on his anterior chest wall. If you look at minimally invasive procedures which have fewer post-implant activity restriction, leadless pacemaker is the way to move forward. And that is why traditionally and now we implant Micra-VR, which is a single chamber leadless pacemaker for all patients with paroxysmal or permanent high-grade AV block in the presence of atrial fibrillation. Also, we give it as an alternative to atrial or dual chamber pacing therapy when the dual chamber pacing system is considered difficult, high risk, or not deemed necessary for effective therapy. From Micra AV, we give VDD pacing for patients with adequate sinus rates who would benefit with maintenance of AV synchrony in presence of paroxysmal or permanent AV block. So these are the current indications as per guidelines. And when you do this in the real world scenario, this is from the Medicare data, then it leads on to a 66% reduction of complications on the long term with a leadless pacing system compared to the transvenous pacing system. And what is this capsule all about? The capsule that I'm talking about is about 1.75 gram, which is the world's smallest pacemaker, 0.8 cc in the volume, 18 mm is the interelectrode distance, but this 0.8 cc device has a battery which lasts about 8 to 13 years, with the newer devices even up to 17 years. It's MRI compatible, it has a very novel fixation mechanism, and you can remotely monitor it as well. Our interaction with this therapy started way back in 2017 when an elderly person came to our ED with ventricular fibrillation. She was defibrillated, and we put in, and this was the rhythm. You can see clearly it's AFib with complete heart block with an escape rate of 26. An emergency temporary pacer was put in, and the patient was fully pacing dependent, but the family was just not willing for a surgical or a conventional pacemaker implant. And so we were in a fix because the patient was fully pacing dependent. The moment you reduce even that pacing rate, the patient develops brady and brady dependent VF. So patient was fully pacing dependent, and the family was just not willing for the conventional pacemaker. That's when our story in 2017 started off with leadless pacing therapy. What it just requires is single venous puncture for right femoral vein access. This is the delivery sheath, actually, which is 23 French inner diameter and 27 French outer diameter. In that, you take in this pacing capsule, the delivery system with the pacing capsule on it, loaded outside, and from the right atrium to right ventricle, you have a deflection. But this is just to show how simple this procedure is. From the right atrium to right ventricle, you get in with the deflection system, get in shoot contrast and check whether you are in an optimal position. The target location is typically a mid-septum or apical septum. Preferably always stay on the septum. So this is the delivery system. We check on with the contrast injection to see whether we are opposed to the septum. On the LEO, it will face the septum. So this is again a shot on the RAO views to see that there's a space between the site of implant and the free wall groove. This is called the RAO space sign. Again, once you've got a good anatomical position, what you just have to do is get the tether out, unlock the button, and this is the deflection button which you use to release the device. So with the press of this blue button, the device is actually released, and then the device is actually, the delivery system comes back, and this is what happens on the endoscopic view. So this is a trabecular right ventricle, and you can see the leadless pacemaker capsule staying in there. This has a very novel fixation mechanism compared to what the leads we have, which is called the fexpitinol nitinol tines. These are the tines which have almost, each of the tine have 8 times the holding force keeping the device in position. So even if 2 tines are fitted in, it has 15 times the holding force to device to stay in. That is what it ensures excellent stability. That's where you find 0% dislodgement rates, and you can actually wirelessly interrogate this device with a wireless telemetry. You can check whether the electrical parameters are good, and once the electrical parameters are good, with the cut of the tether, this device is released into the heart, and then it stays in there. And the patient goes home the next day. The local site is actually closed off with a figure of 8 suture, which can be removed after 6 hours. And patient goes home with the smallest pacemaker inside the heart, and there is no activity restriction after that. This is what it sees on the fluoro. And these are scenarios where we typically use this, typically indicated initially for patients who had complications from the transvenous system, like patients who had Twiddler syndrome, patients who had lead dislodgements because of Twiddler, patients who had pocket erosions, patients who came with pulse generator infections, patients who had lead endocarditis. You see this huge amount of vegetation on the lead. You have lead endocarditis. You have to extract this lead and implant a leadless pacing system. You have a person who has a thrombus on the lead and a patent PFO. This is actually a time bomb where he can have a stroke at any time. These are typical indications for leadless pacing system. This is a fracture of the conventional pacing lead. Again, sure shot indication for leadless pacing system. You see the natural history of any person who gets a conventional pacing system. 70-year-old, complete heart block, gets a dual chamber in 2007. Fully dependent, 100% paced, gets a first generator change after 8 years in 2015, goes uneventfully, second generator change in 7 years time, 2022, now gets infected. This is a natural history of all patients. The more and more time you replace the battery, you are going to get an infected device, and then starts the trauma of these patients. Fully dependent patients, after extraction, what do you do? We do a semi-permanent pacing. We have a pulse generator placed in and a lead placed into the septum. And after that, what is the end point? So we extract this lead, and in the same setting. So traditionally what was done is we put a semi-permanent pacing and then go in for an implant on the other side. It's actually a cumbersome procedure. Now, in this time, we would actually put in a temporary, we would get the infected PG removed, we would extract that, we would take the leads out and implant a leadless pacing system at the same setting. This is the device taken into the septum, anatomical and electrical stability ensured with a tuck test, and then you release the device. So the entire procedure becomes very handy, and the patient goes home. Leadless pacing have almost least incidence of infection because it almost gets encapsulated very soon on. So thoracic outlet syndromes, any venous occlusions, you can do balloon angioplasty, but leadless system is the best way to deal with these patients. CKD patients, where you want to preserve the venous access systems. Young patients, where you want to preserve the venous access system, leadless pacing might be the way forward. Patients with severe TR, you're going to implant a lead in this scenario, you're going to worsen his TR, you're going to give him refractory right heart failure. Better to go for a leadless pacing system in these kind of patients. So traditional leadless pacing systems we have been implanting in patients who have a complication of transvenous system, patients who have higher risk of infections, patients who have anatomical and vascular issues, patients who require infrequent pacing, extremes of ages, patients who have cosmetic requirements. So now we have some safe practice systems where we ensure to minimize the complications. All access are ultrasound guided and with a micropuncture, and finally closure is with a figure of 8 suture. You assess the risk scores of the patient to ensure that patients who are at high risk, we don't re-implant again. You cross with care. That's what we say. We start low, go slow, and pause once you cross a tricuspid valve, and always ensure septal deployment with multiple views and contrast injection. So these are the typical scenarios when we have perforations, elderly patients, patients with chronic lung disease, elderly frail females with a low BMI who are on oral steroids. They are at high risk of cardiac perforation and pericardial effusion. In these patients, the dictum is to minimize the number of redeployments in these kind of high patients. So it's always prudent that you wait for 3 to 5 minutes after initial implant, because most of the time the pacing capture threshold settles after that. So the typical site is to target the mid-septum, avoid the apex, avoid the groove. And when you're going on the typical deployment system, going on the lateral view becomes handy, because if you see on the lateral here, on the LO it looks septum, but on the lateral it is clearly free wall. So if you go on lateral, you can clearly see this is septal, and although on the LO you can differentiate between these two. Again, the RAO space sign is important, because when you inject contrast, there should be a confirmed space between the catheter tip and the chamber border in the shallow RAO, which confirms that you are septal. And this again ensures, so this is the RAO space sign, or the same thing on the LAO. If you have a contrast-free space, that ensures that you're not in the groove and you're not having a higher chance of perforation. Again, the position of the micra, you should always verify as you move the catheter in the LAO. You can see here, if you're on the septum, you will become more perpendicular to septum. So this again, you're on the LAO, you look for the direction of deflection. And then the direction of the catheter always should be pointing towards the spine in LAO. In the RAO, it will be away from the spine, and on the AP view, it will be towards the patient's left. So this is you should position always related to the tricuspid valve as well. You should understand with a shot of the contrast where the tricuspid valve is, where the apex is, and where the septal free wall groove is, because contrast will actually show you good wall contact because it points towards a trabecular structure. And the direction of contrast is also important, because if you have a definite flat flow pattern, so if you see here the contrast injection, there's a definite flat flow pattern which indicates that you are abutted to the septum, and that indicates good contact. But on the other hand, if you are not on the, if you are on the free wall, you can see really contrast just floating on, and that indicates that you're not on the septum and on the free wall. Again, the shape of this oval, shape of the circle, if it is oval, it indicates septum, and if you're seeing a full circle, it indicates you're on the free wall. Again, these are some safety practices which you should do. But again, always during the procedure, you can get wiser with a transthoracic echo-guided implant or even an intracardiac echo-guided implant. Or if in difficult anatomy, it's always wiser to do an RV angiogram, as in these cases, we do an RV angiogram, understand the difficult anatomy, and then get it deployed well. Again, what do you do at end of life? These are now with longer longevities, we are looking at one device for a lifetime with devices which are going to last 16 and 17 years. At the end of life, this is one pacemaker which can be turned off, and an additional micra can be implanted, and an average heart can accommodate at least 3 micra devices, because micra takes up just 1% of the volume of the normal right ventricle, and even if you want, you can retrieve it also and then implant other device. So before I conclude, our experience with device has been over the last 7 years. There are absolute niche indications. We don't go for leadless pacemaker for all the patients. We traditionally always go for leadless pacemaker in patients who have failed conventional pacing systems. So that is where you see we have only implanted about 27 leadless micras. We have done about 4 AVIRs in the last time. So in the last 7 years, 27 micras that we have implanted, 6 were AV devices and 21 were VR devices. 20% of patients had atrial fibrillation. AV block was the indication in 25 of these patients. Almost majority had conventional pacing failures. Procedure time was average 29 minutes. The fluoro time was about 14 minutes. We have absolute stable thresholds on long term. Because the fixation mechanism and the pacing electrode is quite distant, we have stable lead thresholds, almost 0.5 threshold on 0.24 pulse width on the follow-up. We have almost 7-year follow-up of these patients. None of these patients required a replacement. None required a retrieval. No incidence of infections or device failures. We had 1 death after an implant that was related to a severe AR leading on to heart failure, which was nowhere related to the device implant. So to conclude, before I conclude, I would extend my thanks to our team behind, which was in fact the team which was behind the first leadless implant in our state. We also were the team which got the first Micra VR implant in our state in 2017, and the first Micra AV implant in whole of country in 2021. So that's all from my side. I would be happy to take on any questions.
Thank you, Arun. Wonderful talk. So 1 or 2 comments from my side. So we have done 3 implants in pacemaker, infected pacemaker patients, but we avoid doing temporary in these patients. While the patient has a pacemaker, pulse interest still there, infected site, we don't touch that. The lead is still there, and we do micra first, and then we explant the infected pulse generator at the lead in the same time. So we have done 3 cases, and because of its unique coating and better, the chances of pacemaker infection, leadless pacemaker infection is very, very less, negligible. And there is one also large study shows 127 patients with infection. Around 30% of the cases, Micra was implanted first, followed by lead extraction, the same sitting. The idea behind this is the temporary the lead, the electrode, and the delivery system of the Micra, they interact a lot. And most of the perforations which we used to feel that because the Micra it is happening, it was happening because of the temporary lead interaction. You push the device, temporary lead goes in. And that's what we also have seen in one of the workshop which was happening from Malaysia. So they also don't do temporary, especially avoid temporary. So one of the 2 cases which you have shown us, TPI lead is still there. If you are doing the same sitting, you could have gone for Micra first followed by lead extraction. Yeah.
Yeah, your point is well taken, Dilip. We too, although in the case that we showed, we had a temporary placed in, but nowadays what we also do is we implant the Micra first and get the lead extracted. This was the first of the cases which we did. So here we thought it was a slightly longer duration lead, so we thought we were looking at a difficult extraction, and that is why we placed a temporary and got the lead extracted, ensure that we didn't have to use much of mechanical tools, and then got the Micra implanted. But your point is well taken. At all these point of time, it's always better to avoid temporary pacing. It's always temporary pacing induce complications much more than your leadless system hardware is causing complications. So nowadays, we also do the same thing. We just have the conventional pacer giving the backup pacing, implant the Micra, ensure that Micra, but we don't implant the Micra close to a conventional pacing lead. We have at least, if the other one is on the apical septum, we go mid-septum, but at least we ensure some anatomical distance and then extract it in the same setting. I fully agree on that, but that's the current practice. I fully agree.